Okay, guys, let's jump into this voiceover PowerPoint. I'm doing it a little differently. I'm just going to use my instructor notes since it has all of my extras on there. And that's what you guys are going to be looking at anyway inside of the classroom. So chapter 32, lower respiratory system drugs. The chapter starts off by talking about COPD. COPD can be any chronic obstructive pulmonary disease. So asthma, bronchitis, emphysema can all technically be a type of COPD. Now, we're talking about asthma specifically. Asthma is a chronic inflammatory disease. It causes spastic or spasmodic constriction of the bronchi. It is one of the most common childhood chronic diseases, and about 6 million kids in the US actually have asthma. And then even though it's a chronic inflammatory disease, it does have acute exacerbations. That means specific periods of time where the patient gets really sick really fast, or a lot worse really fast, right? And we call these acute exacerbations in asthma attacks, right? So during these asthma attacks, mast cells in the respiratory tract release histamine. They also release leukotriene, but that's kind of complicated. We'll get into that a little bit later. So this triggers an inflammatory response. So the bronchioles constrict, bronchoconstriction. They may even spasm, bronchospasm, which actually encourages more constriction, right? They will swell, there'll be edema. Mucus may clog the small airways as they get smaller and smaller and smaller. The patient may experience dyspnea. Remember, dyspnea is difficulty breathing, wheezing, anxiety. They may also experience tachypnea, and tachypnea is fast breathing. And they might have some chest tightness as well. So when we're talking about medications for asthma, we talk about long-term control drugs, so like your everyday standard preventative drug, and our quick relief acute emergency medications. And so our long-term control drugs for asthma are almost always our inhaled corticosteroids, whereas our quick relief acute emergency meds are bronchodilators, our B2 agonists, and then followed by some type of oral or IV steroid, okay? So it talks about different types of them as we move down. We can talk about the sympathomimetic adrenergic bronchodilators, okay? So our B2s, our B2 agonists. There are SABAs, short-acting, and there are LABAs, long-acting. SABAs are most common, obviously, like albuterol, right? Or terbutaline. So these are the medications we use for emergencies, most often an albuterol inhaler. And then we have our LABAs, or long-actings, and salmeterol is one of those. These medications open up the lungs by causing bronchodilation, okay? Asthma attack, respiratory depression, people who have bronchitis, COPD, emphysema may use these medications. Adverse reactions, because they are adrenergic, that means they're going to be working on that sympathetic immune system. They're going to be working on the adrenergic system, so they're going to be increasing heart rate, blood pressure, respiratory rate, right? And the entire CNS is going to be stimulated. So things like tachycardia, increased heart rate, palpitations, being able to physically feel that, hypertension, increased blood pressure, anxiety, insomnia, potentially even arrhythmia or hyperactivity, okay? Contraindications, allergies. If you're allergic to it, don't take it, right? Tachyarrhythmias, so you already have an existing high heart rate. And then also glaucoma, increased pressure in the eyeball. Interactions, mixing this with other adrenergic drugs obviously will make it a greater effect. That's called an additive effect, right? So if you take another adrenergic like atropine, it's going to increase your heart rate. Probably shouldn't take it if you are also taking medication like albuterol, that's going to increase your heart rate. Tricyclic antidepressants with SABAs and LABAs can cause hypotension. MAOIs can also cause hypertension. We know MAOIs by themselves increase blood pressure, so mixed with these medications that are adrenergic will increase blood pressure as well. When mixed with beta blockers, since these are beta agonists, we're going to have decreased effects of the bronchodilator. That makes sense because they're going to be doing the opposite effect. Methyl-dopa, hypotension, as well as oxytocic drugs. And then theophylline, which is a different type of bronchodilator. It's a xanthine derivative bronchodilator we're going to learn about next, can cause cardiotoxicity if we're using a theophylline drug with an albuterol, terbutaline, or salmeterol. Okay. So you guys feel free to read these slides or take notes on your slides, but I really like to organize everything in the same way and in color. So on the sides is what I am reading to you guys. It's just like my summary. Okay, the next thing we're going to talk about xanthine derivative bronchodilators. So this is the other type of bronchodilator. Examples include aminophylline, diethylene, oxtrophylline, and theophylline. These also cause bronchodilation, but it's because of relaxation of smooth muscle. Okay, so they're going to relax the muscles and allow that bronchodilation. Good for bronchial asthma, bronchospasm related to chronic bronchitis, or emphysema. These are not your first line emergency asthma meds, though. It's going to be albuterol, a SABA. Adverse reactions, same kind of things, tachycardia, palpitations, maybe even some tremors, tachypnea, which is increased respiratory rate, headache, nausea, vomiting, fever, flushing, increased blood glucose. That's a little different, so keep an eyeball on that one. And then alopecia was actually the loss of hair. So that's interesting. Also restlessness, anxiety, all of those psych type symptoms. Shouldn't take a xanthine derivative bronchodilator if you're allergic to it, if you have a peptic ulcer, if you have a seizure disorder, or if you currently have a cardiac arrhythmia. And you should be careful if you have heart disease, hypoxemia, existing hypertension, CHF, liver disease, you're drinking alcohol on a regular basis or abusing alcohol with alcoholism, or you are pregnant or lactating. So a lot of different drugs can change the concentration of theophylline, which can have a bad impact on the heart. So let's just keep an eyeball on that. Barbiturates, charcoal, hydantoins, ketoconazole, rifampin, nicotine, adrenergic agents, isoniazid, and loop diuretics can decrease the theophylline concentration, which that means that the drug's not going to be working right? We don't want that. We don't want to decrease, but we also don't want to increase. That can cause heart issues. So gout medication like allopurinol, beta blockers, calcium channel blockers, cimetidine, which is Tagamet, oral contraceptives, corticosteroids, flu vaccine, macrolide and quinolone antibiotics, thyroid hormones, and isoniazid and loop diuretics. I know that's repeated, that's okay. Can also increase theophylline concentration depending on, your body's particular chemistry or how you handle drugs, your type of pharmacodynamics inside your body. Okay. So be keeping an eye on that, because if we increase theophylline concentration, we can cause heart issues. Okay. 3 types of like everyday anti-asthma drugs. Okay. So these are more of our chronic type of anti-asthma drugs. Inhaled corticosteroids. This is the first one we're going to talk about. Then we're going to talk about leukotriene modifiers and immunomodulators. And lastly, mast cell stabilizers. So corticosteroids, most common ones, budesonide. I'm trying, guys. Budesonide, fluticasone, and mometasone. These are steroids. They're going to decrease inflammation. But remember, whenever we use a steroid, we're not just decreasing inflammation, we're decreasing immune response. So these are good for prophylaxis or giving preventatively for asthma or allergic rhinitis or polyps, but they can cause thrush. So important to teach our clients to rinse out their mouth after they use a steroid. Also can cause upper respiratory tract infection, irritation, potentially vertigo, or headache. If you're allergic to it, if you're having an acute bronchospasm or status asthmaticus, don't be using a corticosteroid. You need albuterol, you need a SABA, you need a bronchodilator, right? Okay, precautions. If you have a compromised immune system already, you're at huge risk for infection. So we probably don't want to give you a corticosteroid that's going to decrease your immune system more. Glaucoma, kidney disease, liver disease, convulsive disorders, diabetes, pregnancy. Be careful. We're going to have to weigh risk versus benefit. The doctor will, right, before deciding to give you a corticosteroid. And then just one interaction here. When you give ketoconazole with one of these, like fluticasone or mometasone, you can increase the steroid concentration in the blood. So just be aware of that. The second class, we talked about leukotriene modifiers and immunomodulators. Examples, montelukast, savirlacast, and salutin. These inhibit the production of those inflammatory molecules, particularly leukotriene, right? Because leukotriene modifiers, that's what we're talking about. And that's going to allow us to have vasodilation instead of vasoconstriction. That's great. It's good because it can prophylactically treat asthma, and it can also treat chronic asthma where you're experiencing like kind of mild symptoms on a daily basis. Headache, flu-like symptoms, anaphylaxis may occur when using a leukotriene modifier. Shouldn't have one if you are allergic to it. If you are having an acute asthma attack, because you should be using a SABA, right, short-acting bronchodilator, or if you have liver disease. Be careful if you're pregnant or lactating. We'll have to weigh it out. Interactions for leukotriene modifiers include aspirin because it increases the concentration of the savirlacast, and warfarin if you mix the leukotriene modifier with warfarin, which is an anticoagulant, you have an increased risk of bleeding. Theophylline, it's actually going to decrease the drug's concentration, so that's not good. And then erythromycin is going to decrease the serum concentration of cefiderocast. So we don't want to decrease the efficacy of our leukotriene modifier. So watch out for that. And the last one, mast cell stabilizers. Mast cell stabilizers include cromolyn, circle it, star it, highlight it. This is an important one. Cromolyn is a mast cell stabilizer. Also, nadocromil, okay? These medications are stabilizing those mast cells. Remember, we learned that those mast cells release histamine and leukotrienes. So if we stabilize the mast cell, then we're not going to be releasing that histamine and leukotrienes in the first place, which is going to cause the inflammation. So decreasing inflammation by preventing the release of histamine and leukotriene in the first place. Uses include chronic asthma, if you have exercise-induced asthma or exercise-induced bronchospasm or allergic rhinitis, adverse reactions to the drug, throat irritation, dryness, maybe unpleasant taste or taste sensation, a cough or a wheeze. And then shouldn't have this if you're allergic or you're having an acute asthma attack. Again, please use albuterol. And then precautions, pregnancy, lactation, impaired kidney or liver function, no significant interactions for mast cell stabilizers. So nothing to stress out about as far as drug interactions. So that is good. Going down to our questions, just so we can, or excuse me, our ADPI. Let's do our ADPI first. Nursing process. What do you need to do before you give an asthma medication? Well, let's get a baseline set of vital signs. Now, obviously, if this is a person having an acute exacerbation of asthma, they can't breathe, let's hit them with some medicine, right? But we're talking about like if we're assessing our chronic asthmatic, we need a baseline set of vital signs. Get a blood pressure, get a heart rate, get a respiratory rate. Listen to those lungs, do a thorough respiratory assessment. Get our history, or do they have any allergies? How long have they had asthma? What type of asthma do they have? What type of treatments have they tried? What triggers their asthma attacks? And then on an ongoing basis, especially after administering a chronic asthma med or maybe even an acute asthma med, we need to be reassessing their respiratory status. So for a chronic med, that's every 4 hours. For acute, that's every 30 minutes. I apologize. My kiddos are getting back from a sport. We also need to check their I's and O's and monitor the efficacy of the drug. Okay, so be listening to those lungs, checking to see if we've got accomplished what we wanted to have accomplished. Nursing diagnoses associated with this issue. Anxiety, maybe from not being able to breathe or from the medication itself, increasing their heart rate, giving them palpitations, make them feel anxious. Ineffective airway clearance from the bronchospasm and bronchoconstriction. Impaired oral mucous membranes, maybe from the steroid causing a thrush in their mouth. Imbalanced nutrition, less than body requirements, maybe due to the inability to, swallow because of the thrush or eat because of the thrush, or maybe even they're just not eating as much because their adrenergic system is more stimulated, so they have less of an appetite. P, planning. We want to see the optimal response, right? Depending on the drug that we're giving. Hopefully it's a better respiratory system. We want to prevent or manage adverse reactions. We want our patient to understand and comply. What are we going to do? Whew, mouthful, huh? So we're going to give epi after we give a rescue bronchodilator to hopefully cause some bronchodilation, but also to support the cardiovascular system, right? Teach the client not to use, especially if we have an allergy, right? We want to open up the areas, but then we want to also counteract that allergy. Teach your client not to use salmeterol more than 2 times per day. Monitor your clients on xanthine derivative bronchodilators for theophylline toxicity. We talked a little bit about this. Too much theophylline, you develop hypotension, potentially cardiac arrhythmia, tachycardia. So be watching for that if you're on a xanthine derivative. Additionally, we want to teach our patient to use, and this is starred, so circle it, star it, highlight it, use that bronchodilator several minutes before the steroid, before the corticosteroid. Why? Because that bronchodilator is going to open up those lungs so that that corticosteroid can get in and decrease the inflammation and swelling so that they can breathe. So bronchodilator opens them up so that the steroid can get in. So bronchodilator, several minutes, at least 5 before the corticosteroid. Okay. Teach your client to rinse out their mouth after they use an inhaled corticosteroid so they don't get thrush. Teach your client to wait 1 minute between puffs of the same medication to allow it some time to work and to get down in the airways, and then do it again. And if your patient is having an asthma attack or they're very anxious because they feel like they can't breathe, make sure you're speaking calmly and you're acting confident to your patient. That way they trust that you have them and that they don't have to panic. If your patient has dry mouth, you can provide some comfort interventions like gum or a candy or a lozenge or some ice chips, or you can provide some oral care. You also, if your client is having a hard time eating for whatever reason, you can offer them small, frequent meals. You can also teach your client how to use a peak flow meter in order to determine if they are about to have an asthma attack because their capacity is down, or just to train their lungs to be more compliant and to take those big, nice, deep breaths with a high capacity. And then if your client is having an acute asthma attack, while they're having that asthma attack and you're managing it with, your SABA, your short-acting bronchodilator, you're giving them the albuterol, you may be giving them a steroid on top of it, right? You're doing all of these things. Make sure you're getting their vital signs every 5 to 15 minutes. Okay. Evaluation in our prior nursing process, we achieved whatever outcome we were trying to. We managed and mitigated any adverse reactions, and our patient understood and complied with the therapy. So here are your questions, and obviously the answers are written on there, so you can only go so far with that, but true or false, asthma is an acute lung condition causing spasmodic constriction of the bronchi and lung inflammation. Many Americans suffer from this ailment, and it is one of the most common childhood chronic conditions. There's really only one word here making this false. So it is false because asthma is a chronic lung condition, but all of the rest of it is true. It is a chronic lung condition, but it does cause spasmodic constriction of the bronchi. It does cause inflammation of the lungs. Many Americans do suffer from it, and it is one of the most common childhood chronic conditions. Question 2, true or false, bronchodilators are used for patients with COPD who experience difficulty breathing, which is called dyspnea, and the interference of gas exchange at the alveoli or smallest level in the lungs there. And that is true. Bronchodilators do work great for COPD patients. COPD patients do experience dyspnea and interference of gas exchange. And the last question, 3, is the following statement true or false? Anti-asthma drugs are used for both long-term and short-term. Yes, and it just depends on what you're using. Short-term is going to be your bronchodilator, right? Acute asthma attack, bronchospasm, bronchoconstriction. We need a bronchodilator, like albuterol. And then our long-term is going to be more like our inhaled corticosteroids, our mast cell stabilizers, our leukotriene modifiers, something like that, in order to reduce the inflammation that they're experiencing to prevent them from having ongoing or recurring attacks. Okay, that is it for lower respiratory. I will see you in upper GI.